Yes,
Yeah.
thank
Yeah, we
you.
can see it.
Perfect. Thank you. Sorry, I appreciate your patience. So thank you all so much for having me. I'm looking forward to talking with you about sleep in our pediatric cancer patients. I do have one disclosure, which is that I receive royalties from this book that I co-authored, but there are no conflicts of interest with the presentation today. What I would like to do is start out with a little bit of a broader view of the number of different medical conditions that are associated with sleep problems in children, and then dive in a little bit more specifically to our patients with cancer and what some of the mechanisms are of sleep disturbance in this patient population, and then end with some interventions that we can actually deliver to improve both sleep and fatigue in our patient population. So, when we think broadly about what medical conditions are associated with sleep problems, certainly cancer is one of them, but we see many others. And any condition that includes chronic or episodic pain is going to be associated with higher risk for sleep disturbance. Any condition that includes inflammatory processes like asthma, arthritis, atopic dermatitis, we're going to see more sleep problems throughout the night. And then certainly any illness that requires nighttime caretaking or has exacerbation in symptoms at night, we see higher rates of sleep disturbance as well. And for those of us who treat children with hematological conditions that are not cancer related, such as sickle cell disease, we also see very high rates of sleep problems within that patient population. And this is important because even in otherwise healthy children, up to a fourth of kids will have sleep problems at some point in their lives. But we know that this is significantly higher in kids with serious illness. And across studies, when we look at children with cancer, we see up to half or sometimes even 60% in some studies that will have sleep problems at some point throughout the course of their treatment or into survivorship. And unlike otherwise healthy children, where we tend to see remittance of sleep problems, oftentimes spontaneously, though certainly it gets better more quickly if we deliver interventions. In children with chronic illness, we don't tend to see this spontaneous remission that we typically see in healthy kids. And when we think about sleep, I think it's really important to focus on what typical sleep looks like in healthy children so that we can recognize where the sleep is disturbed or disrupted. And this is an older study, but I really like it because it shows the ontology of sleep over the course of the first 16 years of life. So, from a developmental perspective, it's nice to depict it this way. What's important to know is that this first year of life, um, which is on the left-hand side of your screen here, there is wide variability in how much sleep children typically achieve over the course of 24 hours. So when we're looking at the 50th percentile in infancy and children receiving about 14 hours of sleep per night, that's across a 24-hour period. So that may be 10 hours at night with a couple of 2-hour naps during the day, but it is a lot of variability. So you can see in that first year of life, we may see infants sleeping anywhere from 9 to 19 hours in a 24-hour period. But once children enter school age, we really see this wide variability begin to narrow, and we have a shorter range from the most sleep that typical children are getting at night to the least sleep. But what we do notice is that across the course of development, the amount of sleep that children are getting at night really decreases over time. And when we look at what is recommended amounts of sleep, and I want to point out this figure is a little bit different because whereas the previous figure was from birth through age 16, this one through the National Sleep Foundation, which is a US-based organization, goes all the way up through older adults. So we really are just looking here at this newborns through teenagers phase. But the decline of what's recommended in terms of sleep is not as steep as the decline in how much sleep children are actually getting. So in healthy children, they are not getting enough sleep, and very often we see this most pronounced in the adolescent period. So we need to think about that in terms of who's most at risk for sleep problems when we are layering on top of that their cancer experience. So, what are some of the common sleep problems that we see? We do see kids when they're going through treatment having more restless sleep. We see higher rates of excessive daytime sleepiness, and this is particularly true in our patients who've had brain tumors and in any patient who's had a traumatic brain injury, which may have been related to CNS directed therapy or CNS related disease. We see higher rates of obstructive sleep apnea, particularly in our children who have developed obesity. Insomnia, and in particular, unrefreshing sleep. So, not just difficulty initiating or maintaining sleep, but sleeping throughout the night, but waking up not feeling refreshed and having fatigue throughout the day. Fragmented sleep, which can come related to medications, treatment related side effects, or pain, nausea, other symptoms that children experience related to their cancer treatment. And we may see more daytime napping, more disrupted sleep at night, and just not having that consolidated sleep at night with alertness during the day. And then moderate to severe fatigue, which may be related to sleep or may be a completely separate entity related to the cancer and its treatment. And sleep is really important. It regulates just about every aspect of our physical and mental health. So we know that sleep is critical for immune and metabolic function as well as tissue repairs. When we think about our children who are having surgeries and needing to recover following that surgical intervention, having adequate sleep is really important for that aspect of their recovery. From a mental health perspective, emotional regulation and cognitive functioning are significantly impacted by sleep, as is overall quality of life. And we really have started to see more data coming out of pediatric ICUs that having adequate and healthy sleep actually does promote healing and is related to earlier discharges. So, when our children are not getting good sleep, what do we see as a result of that? We do see more physical complaints, including more pain interference with daytime activities, longer periods of recovery, longer length of stay when children are inpatient. In children that might have treatment induced diabetes, there is more difficulty with glycemic control because of pain interference, because of fatigue levels and overall sleep impact. We also start to see lower daytime activity, more limitations to what are important or meaningful activities for our patients, where they really need to regulate their energy level and put it towards activities that are of importance to them, like school or social activities. And we can start to see limitations there. More challenges regulating mood. I think most of us know when we don't sleep well, it's more challenging to regulate our mood, and that's certainly true for children. More challenges with learning, which is particularly important for these kids who oftentimes are missing school related to their treatment and may have risk for cognitive late effects depending on diagnosis and treatment there. More challenges with cognitive impairment and more overall social isolation. And when we think about our oncology patients in particular and the role of sleep and immune function, this is really important because we know that our children are already at risk for being immunocompromised, and any aspect of disrupted sleep can further impair that. More challenges with quality of life and mood, which can already be impacted by cancer treatment. Behavior challenges, including decreased adherence to both medication as well as treatment recommendations, and poor uh, integration into social activities, which again is already a risk for our patients. And then, in addition to the sleep disruption, fatigue in and of itself is frequently reported as one of the most common and also one of the most distressing symptoms in our pediatric oncology patients. And because of this, a group of us, including Raphael Van Litzenberg, who's here on the call today, published a call to action as part of the Pediatric Special Interest Group in IPOS, really encouraging sleep researchers to include sleep, encouraging oncology researchers to include sleep within on their treatment protocols and research protocols so that we have a better understanding of how sleep is impacting these areas of functioning in our patients, as well as what interventions we can deliver to make it better and hopefully remediate some of the potential impact longer term in our pediatric cancer survivors. Some of the greatest risk that we see, particularly for sleepiness, is within our brain tumor population. When we look at our brain tumor survivors, they really are very sleepy often. We had several years ago hypothesized that this would be related to a central tumor location. And while that is true, we've also found that tumor location really isn't always predictive, and that we do see high rates of sleepiness even in children who've had brain tumors in other locations in the brain, and that our adolescents tend to be sleepier than children, which is not surprising. Even healthy adolescents tend to be sleepier than children. We know that our adolescents tend to not get as much sleep as younger kids, but this is a patient population that's at particular risk. And then within our brain tumor patients, our craniopharyngioma patients are particularly at risk for sleepiness. We have seen in some of our studies here at St. Jude that up to 80% will meet criteria for either hypersomnia or narcolepsy. And this is persistent and long-term and chronic. It does not remit over time. Those who are obese are significantly more likely to have hypersomnia, and those who are obese and also had hypothalamic involvement preoperatively at a grade 2 level, which means a lot of involvement of the hypothalamus, are much more likely to have narcolepsy. We also tend to see higher rates of sleepiness and fatigue in our very long-term stem cell transplant survivors. So in this study that Danielle Graff led, we looked at 76 survivors who were very long-term, so 5 to 14 years post-transplant, and over a fourth of those survivors were reporting excessive daytime sleepiness. We could not find any demographic or clinical factors that predicted this, so it really just looked across the board. We had a pretty high rate of sleepiness here. We also found that our long-term stem cell transplant survivors were quite a bit more fatigued than the general population, and not surprisingly that those with excessive daytime sleepiness were also more likely to be fatigued. So I think I have hopefully convinced you that our patients are at risk for sleep problems and fatigue. And let's talk a little bit more about what some of these mechanisms might be. I mentioned earlier that in our patients with obesity, they are at increased risk for obstructive sleep apnea. And certainly we have a patient populations who are at higher risk for developing obesity. Our patients with craniopharyngioma or other hypothalamic tumors certainly are at increased risk for hypothalamic obesity. Children who have treatment-induced type 2 diabetes, those who've had chronic steroid usage, and anyone else who's developed treatment-related obesity. We know that our patients with ALL are at increased risk for this as well, may go on to develop OSA. There are specific medications that are frequently used in our patient population that directly disrupt sleep. So anticonvulsants, antidepressants, high-dose steroids, stimulants, in some patients can disrupt sleep, and others they actually can help sleep. So that's a little bit challenging in some of those studies to tease out. Opioids can disrupt sleep, and antiemetics are challenging because oftentimes they're sedating. So if they're being taken during the day, the patients are sleeping or napping frequently during the day, that can then disrupt nighttime sleep. And then any of our patients that have worsening nighttime symptoms can see sleep disrupted as well. So any inflammatory conditions, patients who have epilepsy or other seizures related to their tumors or CNS disease certainly can have more sleep disruption related to that. And then pain, of course, can disrupt sleep. And to take a little bit of a deeper dive into the medications, antidepressants actually can increase sleep latency depending on the medication itself. They also can fragment sleep. So when we think about that unrefreshing sleep that several of our patients will report. Sometimes this is related to medications that they're taking. Tricyclics can be more sedating than selective serotonin reuptake inhibitors, and we don't tend to see tricyclics used for their antidepressant properties as often, though we do see it used frequently for headache management, for example. So we do have patients who are taking tricyclics and need to be thoughtful about impact on sleep there. Antihistamines, which can be used frequently for their antiemetic properties, can cause sleepiness and daytime drowsiness. They also can intensify restless legs, which we may see in patients who have neuropathic pain, and any patients who are iron deficient. So, just something to be mindful of there if patients are complaining about restless sleep. Benzodiazepines, also often used for antiemetic properties, can worsen sleep disordered breathing and also induce daytime sleepiness. Steroids are really challenging because I think subjectively our patients complain a lot, at least mine do, about feeling really fatigued, feeling like they don't sleep well. Um, there are some studies showing that high-dose corticosteroids can prolong sleep onset latency. However, there are other studies that don't find this. So the research on steroids is a little bit equivocal and always challenges me to understand because I don't always feel like it fits nicely with what my patients are reporting to me. So I think there's a lot more work we have to do there. And then with opioids, which are often used in our cancer patients to manage pain, we do see sleep architecture is impacted. So again, when patients are complaining of unrefreshing sleep, some of it may be driven by opioid use. They also can cause patients to feel sleepy during the day. And more chronic use, which we don't see as often, can be associated with the development of obstructive sleep apnea. And then these next couple of slides are going to highlight some significant complexity when we think about sleep in our patients. And when we think about pain, this is a very complex relationship between pain and sleep. Historically, we really had hypothesized this was very bidirectional and that if someone was having pain, they would have more trouble sleeping. And if they weren't sleeping well, they'd be more likely to have pain the next day. And while this is true, there also are a number of complex factors that impact this relationship. Cecilia Valerie has this beautiful model, which I have depicted here, of this interrelationship of the different factors related to pain and sleep. And this also includes developmental stage, sex, gender, race, culture, the socio-contextual factors, biology, physiology, and mood. And it's really important to know that children and adolescents actually report pain following a poor night of sleep more often if they have negative mood as well. And so I think for those of us that do psycho-oncology, this is a really nice reminder that focusing on mood can impact other domains. So we think we have these multiple areas of intervention here that we can help with pain management, we can help with mood management, we can help with sleep, and potentially intervening even in just one of these areas might impact the others as well. And that these relationships then really do have an impact on functional outcomes. So, overall quality of life, how much pain is interfering with children and adolescents' ability to engage in meaningful activities, as well as things like executive function and healthcare utilization. And then I think all of us who have the opportunity to work within the inpatient setting know that the hospital is not typically a very sleep conducive environment. And this is for a lot of very complex reasons. And Berger has this beautiful model that I'm not going to walk through every aspect of, but just in terms of how many different variables really can affect sleep in a negative way within the hospital. And so at the lower left here with the light blue, these are some of the emotional factors related, such as fear, anxiety, stress. We move up clockwise to the purple, which are environmental factors like light and sound, the room that the patient is in, is it shared, is it an individual room, are the caregivers permitted to be there? As we move around the clock to the teal, these disease-related factors, pain, are they having trouble breathing? Have they lost appetite? How long is their stay? What is their glucose management like? Then to the yellow are the more social factors. Is this really an expensive admission for the family? Does that lead to stress? What sort of environmental exposures do they have at home? What is the patient's educational level? Are they missing school? What's the impact on them? The pink factors are more the care related aspects. So, how frequently is the patient having vital checks? What are the procedures that are going on in the room? Is this causing pain or anxiety? And then the bottom right really are some of the internal factors. How old is this child? What is their gender? What is their previous experience of being in the hospital? And all of these really feed into what are the patient's sleep like while they're here with us. And from an inpatient perspective, over three-fourths of studies have demonstrated that there is poor sleep quality and not enough sleep in kids when they're inpatient. Depending on the study, children may be sleeping 45 minutes to almost 4 hours less than what their typical sleep is like while they're inpatient. Pam Hines did a study when she was here at St. Jude showing that there were up to 22 room entries and exits just in one overnight shift, which is a lot of sleep disruption. In adults who've been in ICUs, their sleep disturbance can persist for up to a year following that discharge. In children being discharged from ICUs, 20% have been shown to have significant sleep disturbance 2 to 4 months after discharge. And this is really meaningful for our patients because they very often do not have just one admission like a child in a general children's ward would have. And instead, they have several planned admissions, oftentimes several unplanned admissions. And when we think that the sleep disturbance may be persisting for weeks to months after discharge, and then they're getting admitted again and discharged again, admitted again, we really are compounding that risk for persistent sleep problems. So, in the last few years, there have been a few quality improvement projects and studies looking at what are the environments like, and what are some potential interventions that we can deliver to improve sleep and the sleep conducive environment of pediatric cancer units. So, Andrea Fiddler did this really nice quality improvement project when she was at Dana Farber looking at light and sound on the stem cell transplant unit. They measured light and sound over the course of about 6 months and really found that on an average night, children were exposed to exceedingly loud noise spikes up to 3 times during the night. And these were noise spikes above 80 decibels, which is roughly equivalent to a gas powered lawnmower. So these were at night with sound levels up to 3 or 4 times, like someone was starting a lawnmower in the child's room. These noise spikes happened oftentimes throughout um, the night and were occurring on almost 100% of nights. She also found that there were non-optimal light conditions 62% of the time. So, meaning it was too bright when it should have been dark and too dark when it should have been bright. 98% of daytime hours were spent under dim lighting, and 30% of the night was spent with too bright lighting. So that really highlighted there were some areas that could be improved in terms of how we can set up the environment within the stem cell transplant unit. And then at Cincinnati Children's Hospital, beyond just the environmental factors, Chris Dandoy's group wanted to do a study looking at how could we look at ways of harnessing the circadian rhythm to help promote healing and recovery, again, within stem cell transplant patients. We know that appropriately timed sleeping, eating, and overall activity are really essential for overall health. So humans should be awake and eating during the day under bright light and noise, and should be asleep without processing nutrition at night under dim light and quiet. And so what they did was they did a randomized trial with children receiving stem cell transplant therapy, and randomized them to either receive their standard of care TPN nutrition throughout a 24-hour period, or be randomized to daytime restricted TPN, which typically happened over about a 12 to 14-hour period. And what they found is that those receiving daytime restricted TPN, which is a more circadian, consistent way of having nutrition, had earlier PO intake and shorter admission following stem cell transplant therapy. And this study actually was ended early, partially because of how well those who had been randomized to the daytime restricted TPN were doing. And it didn't seem feasible to continue having children getting 24-hour TPN when they could see that the daytime restricted feeds were better for them. And now Chris Dandoy's group really is advocating for further study of time restricted feeding because it really does seem to have potential metabolic, sleep, and healthcare utilization benefits for patients. And I don't like to talk about our patients' sleep without at least briefly mentioning their caregivers as well. Lauren Daniel did this study of caregivers of children with ALL and found that more than half of the caregivers had clinically significant poor sleep. Fewer than 40% of the caregivers were getting enough sleep at night. And she found that the caregiver's sleep was significantly related to the child's age, how well the child was sleeping, as well as guilt or worry that the caregivers were experiencing themselves. And then in caregivers of children who are dependent on medical technology, almost all of them have sleep disturbance. They have very high rates of poor sleep quality, and on average are sleeping about 6 hours per night, which is significantly less than what's recommended for healthy adults, which is typically 7 to 9 hours per night. And I think this is really important to highlight because our caregivers are under tremendous stress, as everyone on this webinar knows. And we're asking a lot of them. We're asking them to deliver a lot of care to their children. We're asking them to pay attention to a lot of complex information, to make a lot of complex decisions, to regulate some very challenging emotions during very high stress periods. And when people are not getting adequate sleep, it is very challenging to do all of those things. So, as we are working with our caregivers and they may be having challenges with their own emotions, with their own decision making or processing of information, just being mindful of how they're sleeping and how we might encourage or support them in getting adequate sleep to help bolster some of that ability to regulate themselves, I think is really important to consider. So we know that sleep doesn't look great. We know that our environments aren't set up to promote healthy sleep in our patients. So what are some interventions that we can deliver? What are some things that we can do to improve sleep and fatigue in our patients with cancer? When I'm working individually with my patients who are experiencing sleep challenges, there are some common goals for treatment that I typically think about as I'm providing intervention to my patients. One is I really want my patients to have regular sleep schedules where they are sleeping at night and awake during the day as much as possible, that their overall daytime schedules are optimal, they're getting activity during the day, light exposure during the day, they're having improvement in their academic functioning, their social functioning, and that we're identifying what are the most important and meaningful activities for them so that we can help them regulate their energy level to be able to put it towards the things of most importance. And then, certainly for my adolescents and young adults, and particularly those who have daytime sleepiness, that we're really being mindful about how to help them drive in a safe way. So Eric Zhao just very recently published this paper that gives us a little bit of insight into some targeted interventions specifically for insomnia in our patient population. So this was a video conference based insomnia manualized intervention that was just 3 sessions. This really was a proof of concept study just to see, can we do this? And focused on 15 cancer survivors. These were school-aged children. And the interventionists were actually staff who did not have prior sleep education. So they were not licensed mental health professionals, but Eric trained them in this manualized intervention focused on survivor sleep health information called the Survivorship Program. And with just these three targeted video conference based interventions, we found caregiver reported significantly improved sleep and improved quality of life. So this really shows us that there are probably some accessible ways to deliver tailored interventions specifically in our childhood cancer survivor population. And this is newer because most of the interventions specifically for cancer have been in adults. They've been in adult survivors of childhood cancer, but very few looking specifically in this period of pediatrics. So this is showing a little bit of promise, which is really nice. But the evidence in terms of how to tailor interventions, especially for children on treatment for cancer, is pretty limited. So most of the time when I'm tailoring interventions, I'm taking an empirically supported intervention in otherwise healthy kids, and then tailoring it based on how much activity level this patient can have, what their pain is like, how fatigued they are during the day, as well as their cognitive status, and tweaking the interventions based on those potential factors. I also know that very often patients are coming to me on melatonin or asking about being on melatonin, and I feel like I would be remiss to not mention it. It is particularly used a lot in the United States because it is sold over the counter and it is not regulated. In many other countries, in the UK, the EU, Australia, it is available only by prescription. So I think those of you in those countries, there's a lot more control over melatonin usage than here in the United States, where it is the second most common natural product given to children after multivitamins. And in the last few years has been called into our US poison control centers quite a bit as the most frequently ingested substance. They've seen 5 times increase in calls for ingestions of melatonin. And part of that is because of its wide availability, and part of it is because it's often in such child appealing formats like gummies and chewables where it looks like and tastes like candy. So really for those of us in the areas where it's less regulated, just helping families know if they want to use melatonin to keep it away from children and stored safely like they would any other medication. And where it is unregulated, it also is not always what it claims to be on the label. So this study looked at the presence of serotonin within melatonin products. So they weren't labeled as having serotonin, but several of the products did have it. There also was wide range in terms of how much melatonin was actually in each tablet in comparison to what was on the label. And from a concern related to pediatrics perspective, those lower dosages, the 1 milligram and 1.5 milligram, had the greatest variability in melatonin content. Some had double what it claimed to have. Also, the highest variability is within chewable tablets. So again, from a pediatric perspective, that's oftentimes what children are having. So just something to be mindful of if you are in a country where it is not sold only by prescription. In addition, it is really important for caregivers to look at labels carefully because many melatonin products also contain additional natural products like CBD. And the CBD is not always at the rate that the label claims. So it's just important. There really are not good data on giving CBD to pediatrics. So helping parents and caregivers know if they want to give melatonin to their children and you're in a country where it's sold over the counter, that they really need to check the label and make sure there are no additional additives like CBD within the melatonin itself. And there have not been a lot of studies on using melatonin in children with cancer. It has shown efficacy in sleep promotion in children with ADHD and children on the autism spectrum. Outside of those patient populations, it tends to work better as a chronobiotic, so in people with circadian rhythm challenges or jet lag, than it does as a sedative. So just something to be mindful of if parents come asking about melatonin. And then where I'd really like to spend some time is talking about environmental interventions, because I think when we know how challenging it is for children to sleep in the hospital, and we know that a lot of that is because of what we do, I think that we have the potential to have broader impact by reevaluating how we're delivering care, and ways that we might be a little bit more creative and do things differently to promote healthier sleep and hopefully promote better recovery and post-discharge functioning as well. So, over the last several years, we have started to see more of a call for how to optimize inpatient environments. There was a recent editorial in the journal Sleep really calling for sleep friendly designation in hospitals, which is similar to breastfeeding friendly hospitals. The American Academy of Nursing has said that patients really should not have their sleep interrupted unless there is a need to do it, that either their condition is necessitating it or a care that has to be delivered. The Right Care and Hospital Medicine program has really issued a top recommendation that inpatient hospitals need to be finding ways to support healthier sleep in inpatients. And the National Sleep Foundation of the United States has really said that prioritizing sleep is a very important step in improving health in patients who have challenging social determinants of health. So we know that patients that have more challenges in their social determinants of health are at risk of greater healthcare utilization, poor outcomes, and promoting healthy sleep is a pretty cost effective way to have more of an impact overall. So a few years ago at the University of Chicago's Children's Hospital, they thought maybe we could consider reducing overnight blood pressure monitoring in some patients with this improved sleep. And so they created this siesta program, this sleep for inpatients, and empowering staff to act, and had these badge buddy cards that were distributed to nursing staff to help people know who really needs to have blood pressure taken overnight and who might not need that. So, some patients who have serious bacterial infection, hypertension, anaphylaxis, cardiac disease, they need overnight blood pressure monitoring, but maybe other patients don't. And can we just let them be and not go in and take their blood pressure every 4 hours, which in pediatrics wakes kids up? We know that. And then, in addition, really helped staff think about other ways to improve patient sleep, like being quieter out in the halls, silencing phones and pagers, batching tasks, or bundling nursing care. And what they found is that caregivers here in the light gray, that's the pre-intervention, and the black is post-intervention, really did see a decrease in disruption from nursing staff, from the pulse ox, a little bit less from vitals. But what they found is they didn't see much change in their infants and toddlers in terms of their sleep. But in the kids over the age of 2, caregivers were reporting that they were getting more sleep at night when they reduced the blood pressure monitoring and tried to bundle some of their care. And then Lauren Daniel actually presented this at the PPO meeting at PSYOP in 2023 in Ottawa, looking at extending time between vital signs in stem cell transplant patients. So this was a study done at Children's Hospital of Philadelphia. They took 40 transplant patients between the ages of 8 and 21 and randomized them to either receive their typical Q4 hours vital signs or extend the time between vitals to 6 hours, and they were randomized either during days plus 10 to days plus 14, which was group A, and that's in the light blue, or during days plus 5 to plus 9, that's group B in green. And they had parameters around this. So they were only eligible if the patient hadn't had a fever in 24 hours, wasn't getting current chemo, didn't have an active infection, and didn't have an organ toxicity that would require labs occurring more frequently than that. And what they found is that extending vital signs to Q6 hours was feasible and it was acceptable. They didn't have any adverse events related to the extended vitals. And what she found is sleep efficiency, which was the percentage of time between bedtime and wake time that they actually spent sleeping, got worse days 0 through 4, which I think we all would have expected. And extending the vital signs days 5 through 9 really didn't make much of a difference. So they were early post transplant, not sleeping well, extending the vital signs during that time period didn't really seem to have a whole lot of an impact. However, for those who had their vital signs extended during days 10 through 14, they did see a difference, and their sleep efficiency was significantly better during those nights. And not only was it statistically significant, but there was a clinically meaningful difference. So they were spending 5% more of their nighttime asleep than those who were getting vitals taken every 4 hours. And what was also nice is that the patients, the caregivers, and the nursing staff all supported extending vital signs out to Q6 hours. So this is something different, and especially on a stem cell transplant unit where patients are pretty critical. It's exciting to see that there is this intervention that was feasible, that they didn't have any adverse events, and that actually the patients were able to sleep better during that time. And then again at Cincinnati Children's, because if you remember, this group had identified some challenges within their transplant unit. They engaged families and nighttime staff to see how could they reduce noise on their unit. This chart here is looking at how many spikes are above 60 decibels, which is about the sound of a busy street or an alarm clock. World Health Organization recommends that overnight sound be below 40 decibels, but they really were trying to just keep their sound from spiking up so loudly that would induce wakefulness. So they engaged their families, they engaged nighttime staff, and found that nighttime cleaning was pretty loud, so they made that less intrusive. They had the last trash pull at 9 p.m. They reduced the noise and put door stoppers on doors, closets, wall-mounted workstations within the rooms, and created a night ninja nursing program for the nurses to be quieter. And what you see here with C and D, where you really see this drop in the noise spikes, is when they put the sound dampeners on the doors. So that really helped them know that it was helpful to reduce the intrusiveness of the nighttime cleaning, but dampening the sounds of doors and staff entering and exiting and opening cabinets really did seem to make the biggest difference in terms of reducing the number of noise spikes that they had. So here at St. Jude, seeing that there have been some promising results of some environmental interventions elsewhere, we wanted to undertake how we might improve sleep within our ICU. And so we developed a quality improvement project to see what was disrupting sleep in our ICU and see what sorts of interventions we could deliver on the environment of care to promote better sleep. So at our baseline, we looked at the sleep and environment of 27 patients between the ages of 2 and 20. They all had to have an anticipated stay in the ICU of 2 or more nights. And we put sound meters and light meters within each of their rooms, and then had 15 patients, our older patients, wear actigraphs so that we could see what the relationship was to their sleep. And what we found, which is very similar to what I showed earlier in a couple of other hospitals on their stem cell transplant units, is that our ICU is really loud. There was very little variability across days and night. Again, World Health Organization recommends that overnight sound be below 40 decibels, and it never was at any point. We had 0% of time when it should be a sleep conducive noise level. Conversation level sound was present more than 95% of the time, and we had 0 quiet minutes over a 24-hour period. So that let us know that we had a lot of opportunities for improvement. We also found with light that there was very little variability across days and nights. It was dark throughout the day. Typical daytime light is above 199 lux. We had less than 5% of time spent in typical daytime light. And this is important because light exposure really is one of the most key factors in promoting a healthy circadian rhythm. We're just not doing that for our patients in the ICU. And it should be light and loud during the day and dim and quiet at night, but it's light and it's dark and loud all the time, which is never a circadian factor that humans should be experiencing. So we're really finding ways that we're setting our patients up for risk. And so I'm not going to go through every aspect of this, but just to show you, we were very thoughtful about um, how we could intervene to improve the environment of care and hopefully see better impact on patient sleep. We included a lot of ICU physicians, nurse practitioners, nurses, um, nurse manager, nursing researchers. We have a patient caregiver who's part of our team, and having the input of so many different people on the team really helped us identify a number of areas where we could potentially intervene here. We came up with this concept of the stealth superhero for our nursing staff with a daytime plan where there's activity during the day, lights are on, blinds are open. This is part of an early mobility bundle in our ICU, so having patients out of bed as much as possible, and then having a quieter, darker night with less activity, white noise to help them sleep better. We also focused on noise reduction. So we have the white noise machines within the room, our automatic doors, which are pretty loud. We switched to manual mode at night so the staff can come in and out of the room without the door making a loud sound opening and closing. You see the stoplight here. These are out at the nursing stations at night. So as the noise level increases, it will change to yellow to notify the staff that they need to lower their volume a little bit, or if it turns to red, they really need to lower their volume. We are fortunate that we have beautiful natural lighting in our ICUs, so we really want to take advantage of this and have the blinds open during the day so that patients are getting exposure to natural light. So with these interventions that we delivered, we found that with noise, we still have a lot of room for improvement. We still have very little variability across days and nights. We still are seeing zero quiet minutes, and we still are having conversation level sound more than 95% of the time. So we are still developing other interventions to work on the sound because we just haven't quite gotten there yet. The news on light is better. So we are seeing better variability across days and nights. More than twice as much time is spent in low light during the day as was in our baseline. And we now are almost at 10% of the day in typical daytime light. So we still have a lot of room to go, but we are definitely seeing improvements in having our patients exposed to light during the daytime. And what's great is we also see that this has impacted sleep. So we have been able to see extended sleep duration at night, better sleep efficiency, and less wake spent after sleep onset. So they're still spending an hour and a half after they go to sleep awake, which isn't great, but it is better than it was. And we're encouraged by this, which is driving us to our wave 2 interventions, which is that we have formalized education for our patients and families. We're recording the use of these white noise machines to see how often that's happening and how much that's impacting our noise meters. And then having barcodes across the armband so that we can twist the armband and not wake the patient, not have to twist the armband to scan for medications and blood products and not wake the patients as much. And this is just a little example of sleep and activity in the ICU education designed for parents and caregivers. And this is available on the Together by St. Jude website, which is a freely available resource. It's available in 12 languages currently. They're adding languages all the time, but anyone here can go to together.stjude.org. There are a number of sleep education materials on there. And this one is specific to the ICU, but there are many others on there that you can use with your patients and families to help them understand how to manage sleep problems and fatigue in their children with cancer. And with that, I'm going to stop and I'm happy to take any questions.
Thank you so much, Dr. Valerie. I think it was a really insightful session. And I think now the stage is open for any questions from the audience. I think we have another 5 minutes that we can take for the questions.
I thought I saw a hand up, but maybe not.
I don't really see any more hands for questions, but I actually wanted to ask one thing. I don't know how the scenario has been in other places, but what we see at our setting is that because there's a lot of risk of infections, kids are not allowed to go out for a lot of physical activities and they are very much homebound. And because of that, the screen time tends to increase. So most of the times it tend to be on their screen, whether it's going to be their laptops or their phones. And it's not only with the patients, but I think even with the caregivers. Um, Even the parents, we see them being a lot of time, spending a lot of time on their phones and TVs, and a lot of screen time is there. So, is there any intervention which you at your institute try to intervene in such situations, or how do you handle these cases?
Yeah, I mean, I see the exact same thing. There's so much screen time in our patients and in their caregivers. And I think if they're not able to go outdoors because of infection control reasons, I do recommend that families still get natural light exposure so that they're opening blinds, they're sitting near the window if they can, at least getting a little bit that way. And then there also are light therapy devices that can be used that do not have UV rays. So they're, if they're on any type of UV sensitive medication, it doesn't harm them because there really is not UV in there. So they can wear those as glasses. They can have boxes that they sit in front of for half an hour in the morning, and that can help with circadian rhythm. And then from a screen usage standpoint, one of the things that I really like to work on with, especially my adolescents that are having trouble with sleep onset, is what the intensity, and I mean like emotional intensity of that screen activity is at night. So if they are on some of the apps that are like rabbit holes of content that just go and go, like TikTok, that just go and go, and there's not a natural stopping point. Or if they're engaging in video games that are really stimulating and hard and multiplayer and hard to stop, that in the evening they switch over to something like a TV show or an episode of something so that there's a natural end and that there isn't this constant dopamine hit, but also pull to stay engaged in the activity. Because I think a lot of times, and there's more evidence coming out about this, that being pulled into the engagement and the activity is what interferes with sleep even more than the screen itself does. So I really try to think about what the screen activity is and how to modify that in the evening to help them get ready for bed a little bit better.
Yeah, thanks for that. And we see a lot of comments here in the chat. Nicole was here. Nicole says that this was fantastic. Thank you so much. Jessica says that thank you very much for a very great and informative talk. And there's one question from Maria which says that when you have patients that wake up at 12 to 1 a.m., I feel that's a.m. Do you let them sleep that much or try to wake them for the day? Um, I think she wants to consult and try to make them sleep. She wants to consult how to make them sleep to have a normal sleep. Usually they go to sleep at 11 p.m. or 12 a.m.
Yeah, it really depends on the patient. So if they have treatment needs or care engagement needs earlier than 11 or 12, then I will work with them to help them set up a schedule where they're going to sleep a little earlier and waking up a little earlier. But if they don't, if they're, and I do that, and to tell you the truth, When I worked in the sleep clinic and I worked with adolescents and young adults who could set their own college schedule or work schedule, I would do the same thing. If you naturally sleep from 11 p.m. to 11 a.m. and you don't have to do anything before noon, there's nothing wrong with that. And a lot of people who work second shift, that's the reason they do it, is that they're night owls. It's easier for them to maintain a sleep schedule like that. And that's really not a problem. Um, but, if they're missing their physical therapy appointments, if they're missing getting to their school, meeting with their school teacher and things like that, then yes, we need to shift it. So it really depends on what their needs and goals are. And I see Andrew, thank you, Andrew, for adding that. Um, this additional information about he put in the chat additional information about early mobility, even if they can't leave the room, which is another great article on the Together by St. Jude website.
Yeah, so I think this brings us to the end of today's session. Thank you so much, Dr. Valerie. I think this was a really, really fantastic session. I think very interesting. We never had something like that in our previous sessions, and looking forward to be in touch with you in case we need any more information.
Absolutely. Thank you so much. I really appreciate you all inviting me and listening to me today. Thank you.
Thank you. Thank you so much
Thank
for joining in today. And once we have the recording of this session, we will share it on our group. Hope to see you all again. Thank you so much. Have a great day.